Good afternoon, everybody. Welcome to today's acid-base conference. Today, we're going to be giving you questions after each case like before, but now we're going to be recording your answers. So Jacqueline's going to be doing the polling after each question, and we'll see how everybody does, and then I'll give an explanation as to why the correct answer is what it is. So before going on to the questions, I just wanted to review again the so-called acid-base rules, which you need to memorize and know to diagnose each of the simple disorders. So there's the choice that the bicarbonate is decreased or the total CO2. Once you see that, you then decide whether it's a metabolic acidosis, acute respiratory alkalosis, or chronic respiratory alkalosis. And each of those has a different change in bicarbonate to change in PCO2. So for metabolic acidosis, it's approximately 1-to-1, which means the decrease from normality is about equal for each of those. In acute respiratory alkalosis, for a given fall in the PCO2, the bicarbonate falls about a fifth of that, or if you want to remember, 10-to-2. And in chronic respiratory alkalosis, for every fall in the PCO2, the bicarbonate falls half of that. Or if you want to remember, for a fall of 10 in the PCO2, the bicarbonate falls by 5. And then if the bicarbonate is increased or the total CO2 is increased, again, it's one of three choices. It's either a metabolic alkalosis, acute respiratory acidosis, or chronic respiratory acidosis. And again, you distinguish each of these three, which you have to memorize, because they each have a different change in bicarbonate to change in PCO2. So if it's metabolic alkalosis, the PCO2 goes up about 7/10 of what the bicarbonate increased, and we call that a compensation. In acute respiratory acidosis, for every increase in the PCO2, the bicarbonate goes up by about 1/10 of whatever the PCO2 went up by. And if it's chronic respiratory acidosis, the bicarbonate goes up by about 1/3 of what the PCO2 went up by. These things don't occur immediately. The change in the PCO2, which we call the compensation in metabolic acidosis, takes about half a day to a day till it reaches completion. In metabolic alkalosis, it takes a bit longer, a day to a day and a half. And in chronic respiratory acidosis, it takes about 3 to 5 days for the bicarbonate to increase to its final steady state. And in chronic respiratory alkalosis, it's a bit shorter. It takes 2 to 3 days for the bicarbonate to decrease till its final value after a decrement in the PCO2. Okay, so these things you just have to memorize. They're not logical. There's no way to predict them. But if you know the 6 rules, you'll be able to make the diagnosis of simple acid-base disorders. So here's the first question. It's a 27-year-old who was admitted with a 3-month history of shortness of breath. And you can see here, there was also polyuria. The exam showed a pressure of about 90 and in tachycardia, the JVP was flat and the extremities were without edema. So for each of these, there's going to be one question. What is the acid-base diagnosis? So we're not asking what the clinical cause is or what the clinical syndrome is. Just from the acid-base numbers, what is the acid-base diagnosis? So here are your choices. And Jacqueline, if you can share the poll. So if you could please enter your choice and take about a minute and a half.
Can we take a look at the numbers again, please?
Yeah, sure. Okay, so now we'll give you the choices.
Is there a way to get to the poll? Sorry, I'm trying to like figure that out. I'm just trying to.
You mean entering on the poll?
Oh, here we go. Okay, I got it. Sorry.
Okay.
I found.
No problem. No problem. If anyone else has any trouble, let me know. And let us know when you're all done. And everybody should commit. Don't not enter an answer. It looks like 3 of you have done it. Those that haven't, if you could please enter your answer. Okay, 4 people have answered. Is there anybody else? Yeah, I think there's a few more. How many people are there on the call? Is that it, Jacqueline? Has everybody answered?
I think we're waiting for one more.
Okay. Who is that?
Not sure actually
Okay.
who that is.
Okay, well, for the sake of time, we'll end the poll. So 2 people thought it was an anion gap metabolic acidosis, and 2 thought it was a metabolic acidosis and a respiratory alkalosis. Okay, so let's go back. Yes, the correct answer is a compensated metabolic acidosis. So and it's the anion gap type. So the correct answer is 4. Clearly, there's an anion gap. Now, why isn't this a respiratory alkalosis? It would be a respiratory alkalosis if the PCO2 was below what you expect. So again, if the PCO2 is exactly what you would expect in a metabolic acidosis, in other words, the fall in the PCO2 is roughly what the fall in the bicarbonate is, then you don't call that a respiratory alkalosis. That's called appropriate compensation or a compensated metabolic acidosis. It's only if the PCO2 is below 28 or below roughly this. So the expected fall is roughly what the bicarbonate fell by. Here they both fell by the same amount. Again, we don't know the original numbers, so we're assuming, but if it's a female, the original bicarbonate's probably around 23. The most it would be 24. So the fall is 9 or 10 from normality. So we'd expect the PCO2 to fall by roughly 9 or 10. If normal PCO2 in a female is 37, 38. So the change is the same for both. You don't call the fall on the PCO2 a respiratory alkalosis because you only use that word if it's excessive compared to what you'd expect. So that's a very, very important point. So on your exam, do not call this a respiratory alkalosis. It's called, and you don't call it a secondary respiratory alkalosis even. It's just called appropriately compensated, which means that the ventilatory system is increasing the excretion of carbon dioxide exactly what a normal person would do. It's only if it's below 28, like if it's 24 or 25, you would call that a metabolic acidosis of the anion gap type. plus a respiratory alkalosis. And it's only if it's over 30, 31, 32, would you call it a respiratory acidosis? And that people find very hard to understand. How can it be 31, 32, and you're calling that a respiratory acidosis? But it's the same thinking again. It's because 28 is your new norm, not 38, 39, or 40. The terminology for whether it's respiratory acid-base disorder is not based on whether it's 40 or 39. It's based on whether it's what you would expect for the compensation. So that's a very important point diagnostically. Okay, good. So let's go to the next case. So this is a 34-year-old female who was admitted with a history of diarrhea, hypotensive, again, flat JVP. And these are the numbers. Again, we're not talking about the clinical cause of the numbers, just the acid-base diagnosis. So once you've got those numbers down, you might want to just write the relevant ones. Again, calculate whether there's a gap, and then write down the total CO2 and pH, PCO2, and bicarb, and then I'll show you the choices. Okay, so here are your choices. And Jacqueline, if you can show the polling.
Sorry, can I just see the numbers really quick again?
Sure.
Got it. Thank you.
I think we're waiting for one person.
Yes.
Okay, so we've got a pretty big spread there. So let's go back to the numbers. So again, if the bicarbonate's down, it's either metabolic acidosis or acute or chronic respiratory alkalosis. And then you look and see whether the changes fit each of the three. If it doesn't, you have a mixed disorder. So the bicarbonate, or the total CO2, it's a male. The normal's around 25, 26. So the fall is about 15, 16 or so. And all you have to answer is the fall on the PCO2 the same, or which would be a compensated metabolic acidosis, or is it what you would expect for acute or chronic respiratory alkalosis? And you can see again, it's the same as the last question. The changes in the PCO2 and bicarbonate from normality are roughly equal. And the only acid-base disorder that can be is a compensated metabolic acidosis. Again, we don't call the fall on the PCO2 a respiratory alkalosis unless it's below 24. So 24 now becomes your new expected value. So again, it's quite simple. If the fall on the PCO2 and the bicarbonate are almost identical, the only acid-base disorder you can have is a compensated metabolic acidosis. It doesn't occur in the others. The change from normality for each of those values is not equal. If it was acute respiratory alkalosis, it would be roughly a 10th or a 5th of the fall in the PCO2. And if it was chronic respiratory alkalosis, the PCO2 falls twice as much as the bicarbonate fell. It's 2 to 1. So this, in fact, is the easiest pattern to recognize because the fall is equal. So again, similar to the first question, the change from normality is equal here. So it's a compensated metabolic acidosis. And the change from normality here is the same for both. They both fell by roughly the same amount. So both of these questions, the correct answer is a compensated metabolic acidosis. In one, you have an elevated anion gap, and in the other, you don't. Okay. Here's another case of a patient who was admitted with a long history of cough, shortness of breath. You can already possibly even guess what the acid-base disorder will be. Patient had green sputum, mildly cyanotic, or at least you know the clinical category. And here are the numbers. So the total CO2 is 36, and the PCO2 is 72, and the bicarb is 34. So again, you have an elevated bicarbonate. So it's one of three acid-base disorders if it's simple. So write those numbers down, or at least the relevant ones, and let me know when you're ready to see the choices. Does everybody have those numbers down?
I'm ready.
Okay, here are the choices then. And if you can put up the possibilities. Okay, let's go to the case. So we have an elevated bicarbonate, and it's got to be either a metabolic alkalosis that's compensated or acute or chronic respiratory acidosis. It doesn't fit compensated metabolic alkalosis, and it doesn't fit acute respiratory acidosis. The only one it fits is chronic respiratory acidosis, and the rule is that for every 10 increase in the PCO2, the bicarbonate goes up about 3.3, 3.5. So here the bicarbonate went up. We don't, again, the problem with all of these things is we don't know the initial values, but let's say it was 25, the bicarbonate, or 24, the bicarbonate went up 9 or 10. That means that the PCO2 would have to go up a little over 30 for at least 3 to 5 days for that bicarbonate to increase and then steady state out at around 34. So of all the causes of an increased bicarbonate, the only disorder that fits is a chronic respiratory acidosis. So that is correct. Again, with the history, you likely have chronic obstructive lung disease. And the acid-base disorders are usually chronic and respiratory, and it's either chronic respiratory acidosis if it's someone with chronic bronchitis, or it's chronic respiratory alkalosis if it's someone with emphysema. Those would be the extremes. So this is likely a chronic. If you see these numbers, it's not emphysema. It's got to be chronic bronchitis. Okay, here's the next case. It's a 53-year-old male admitted with a history of nausea and vomiting. With some right upper quadrant tenderness, hypotensive, and tachycardic. So again, we're not talking about the clinical cause of these things, just what the chemistry is. So let me know when you have those numbers down, and then we'll go to the choices. Okay, does everybody have the numbers before I give you the choices to pick? Okay, so here are your choices. We're waiting for one more person. Oh, unless someone left. Do we have everyone, Jacqueline?
I believe we're waiting for one more person.
Okay. Okay, rather than keep you waiting, let's just go to the approach to this case. Okay, so in this particular case, we have an elevated bicarbonate. So again, it's either metabolic alkalosis, compensated. Again, these are simple disorders. Doesn't have to be compensated, but if it's simple, metabolic alkalosis compensated or acute or chronic respiratory acidosis. Those are the only causes of an elevated bicarbonate. And if it's metabolic alkalosis, remember that PCO2, you get what's called a compensation in your ventilatory system, such that the PCO2 goes up 7/10 of what the bicarbonate went up. If it was acute respiratory acidosis, the changes are 10-1. It's the bicarbonate increase compared to the PCO2 would be 1/10. So clearly that's not the case. And in chronic respiratory acidosis, as I mentioned, for every 10 increase in the PCO2 as the initiating event, the bicarb after 3 to 5 days will go up about a third of that, 3.3 to 3.5 for every 10 increase. So it looks like it's metabolic alkalosis. Let's just see. Again, we don't know the initial numbers, but the bicarb went up about 10. So you'd expect the PCO2 to go up by about 7. And that's exactly what you see here. So these numbers fit perfectly with a compensated metabolic alkalosis. And clinically, it makes sense because the patient was vomiting. You've got a clinical cause. And that wouldn't per se mean you're right, but at least it's compatible with your acid-base diagnosis. Okay, so the answer to this question is a compensated metabolic alkalosis. So this is a 25-year-old with a history of glue sniffing. And here are the numbers. The pH is 732, the PCO2 is 28, bicarb 14, total CO2 15. So write those numbers down. And here are the choices. Does anybody want to see those numbers again? Okay. Anybody else? I think we might have lost another person. Okay. All right, so let's go back here. So again, we have a drop in the bicarb. So it's either metabolic acidosis compensated or acute respiratory alkalosis or chronic respiratory alkalosis. And again, we just check and see if the changes are equal, in which case it would be a compensated metabolic acidosis. And if it is, we don't even have to go to the remaining two possibilities. And so it is. Again, you have a case where the bicarb fell roughly what the PCO2 fell. They're not exactly the same, but again, the fall isn't exactly the same as far as the prediction. It's roughly 1.2 to 1. So the question always is, how close does it have to be to 1 to 1? And that really no one can tell you, but it's sort of a feel that you get, and you can get very granular and say, well, it doesn't fit the rule exactly. But the problem is, this is the 1-to-1 rule, or if you want the Winters formula, these are just averages of large populations, and they don't apply necessarily in a given individual, so you have to give some leeway. But in general, if you get the impression of equality in the change in bicarb from the change in the PCO2 in the down direction, not talking about in metabolic alkalosis because they're not equal, it's 7/10. But if the numbers in the decreased direction are roughly equal as from their original levels, that's just a compensated metabolic acidosis again. So another case of the same thing. The clinical cause in glue sniffing, which we won't get into details with, is because you get hippurate made, hippuric acid made, and you don't get an elevated anion gap because the hippurate's excreted. So it's a non-gap acidosis, even though the cause is an organic anion acidosis. There is an organic anion coming up with the proton, but the organic anion is so easily excreted that you don't get an elevation of your anion gap. The anions are all in the urine, and the chloride goes up then to maintain electroneutrality. Okay, here's a interesting case. It's a 20-year-old with severe chronic vomiting, admitted to the hospital with orthostatic changes, and the patient looked volume depleted. And here are the numbers: pH 7.4, PCO2 41, bicarb 25. And this type of question is often on the boards. Okay, so let's go to the questions now. What are the choices? go back to the numbers here. So this is a trick question for a number of reasons, because none of these answers are correct. So first of all, there's an elevated anion gap, right? So the anion gap here is 86 plus 26 is 112. That's 20. The anion gap's elevated. The only answer with an anion gap metabolic acidosis is with a respiratory acidosis. And that certainly wouldn't give you numbers that end up being normal. You couldn't have a PCO2 of 41 and a bicarb at 25. So this is the type of question they will give you on an exam. The answer is a metabolic acidosis and a metabolic alkalosis that are equal in magnitude. And if they had just said on the answers metabolic alkalosis and metabolic acidosis and didn't specify whether it was anion gap or not, then that would be the right answer. So this is a patient who's vomiting, who could have gotten lactic acidosis, or maybe it was even ketoacidosis. And the reason the numbers are normal is because they're equal in magnitude, but opposite in direction. So this type of case brings up the point that you're always looking at the net effect on the PCO2 and bicarbonate. That's why we use the words osis, not emia. So metabolic acidosis means a process that would tend to cause the blood to be acidemic from a metabolic reason. Or respiratory acidosis means a respiratory process that would tend to cause the blood to be acidemic. But it doesn't mean the blood will be acidemic, because you might have other disorders that change the numbers in the opposite direction. And if you have two acid-base disorders that are changing things in opposite direction, but they're equal in magnitude, you're going to end up with normal numbers. So this is a trick case, in that having normal numbers does not mean you don't have any number of osis, either alkalosis or acidosis. You don't know if it's one or more, you don't know how many, but you could have a whole bunch of them that just end up causing the blood to be normal, and you can be really fooled. Now, if this was a case of a non-gap metabolic acidosis, you wouldn't even have an elevation of your anion gap as a clue. At least with this case, you know there must be a metabolic acidosis there, because the anion gap's elevated, and whenever it's elevated, the anion always came into the blood with a proton. So the only question then is, if I have a process putting a proton and an organic anion into my blood, why isn't my bicarbonate below normality? Well, just from that logic alone, even without analyzing it in great depth, you know, a priori, there must be a process which is elevating the bicarbonate. And then your thinking is, well, if there's a proton coming in, as evidenced by the organic anion or the anion gap going up, and my bicarbonate's normal, which means there must be a process elevating the bicarbonate in the opposite direction, you know that they must be equal in magnitude, causing the net bicarbonate to end up not changing from normality. Now, you don't know any temporal information. You don't know if the vomiting caused the bicarbonate to go up first, and then the anion came in with a proton afterwards and brought it back to normal, or whether they happened simultaneously, or whether the proton load occurred first. That there's no temporal information, whether you had one before the other or simultaneity. All you know is at this snapshot in time, there must be at least two acid-base disorders that are opposite in direction and they're equal in magnitude. So this kind of question, where you have what looks like on the face of it normal numbers, but two acid-base disorders. Now, the acid-base disorders don't always have to be metabolic, but that will be the answer they give you on the test. And they really are the only two acid-base disorders that are opposite in direction, where you won't have the PCO2 out of kilter, where the PCO2 will also be normal. So for the exam, the correct answer for this question, had it been one of the choices, which it wasn't, is an anion gap metabolic acidosis with a metabolic alkalosis. And in your head, you know, they must be equal in magnitude, and that's why you end up with normal numbers. So the teaching point for this last question is that normal acid-base numbers do not at all rule out multiple acid-base disorders. They rule out a single simple acid-base disorder, but the teaching point here is normal numbers can equally arise because you have multiple acid-base disorders that would tend to change the numbers in opposite directions, but they're equal in magnitude, so you end up with no net change in your blood chemistry. So I think we'll stop here today, and if anyone has any questions, please let me know.
Quick question.
Sure.
The respiratory status of this basically is not playing a role into this at all, right? Because you were saying it's metabolic acidosis, anion gap with a metabolic alkalosis.
Yes.
So in this scenario, we're just supposed to recognize that there is no respiratory process.
Yes, so that's a very good question, because you would think if you had a metabolic alkalosis and a metabolic acidosis that the PCO2 could not end up being perfectly normal, because if there was a metabolic acidosis, the PCO2 should fall by the same amount as the bicarb. But if you got the metabolic alkalosis, it should only change by 7/10. So if you do things sequentially like that, just to think about it, how could the PCO2 ever return to normal? And that's a paradox which has never been answered. I think that might be the gist of your question. It would only be if the compensation for the metabolic acidosis and alkalosis was 1-to-1. In other words, the change in the PCO2 versus the change in the bicarbonate for both acid-base disorders was roughly equal, that you would expect the PCO2 to be normal. I don't know if that's what you're asking, but
yeah, that makes perfect sense, because I was just like,
but
yeah.
Since we know that the change in the PCO2 is 7/10 of the change in bicarbonate for a metabolic alkalosis, you can justifiably ask, how could the PCO2 return to normal? It should be, you know, a little bit below what normal is. So in other words, let's say the lactic acidosis here, or the ketoacidosis, caused the bicarb to fall to 15, and the PCO2 would fall to about 30. And now we vomit and bring the bicarbonate back up to 25. The PCO2 should only go back to 37. It should not go to 40. But then that brings up the paradox. How could you have a normal bicarbonate with the ventilatory system still hyperventilating? So
Yeah, that makes sense.
So no one has answered that question, but the only answer that one could give is that these rules apply separately, but not when you have more than one acid-base disorder present. And I'll give some examples in later lectures where that is true. We have these 6 rules, but no one has looked to see whether they are actually true when you have more than just one acid-base disorder present. And I know that sounds complicated, but for now, you should memorize those rules and use them only when you have a simple disorder. Clearly, if we had a 7/10 change in the PCO2 for the change in bicarbonate, it just wouldn't make sense intuitively. How could we have a bicarbonate that's decreased by 10 from the organic anion acidosis, now brought back to normal with the vomiting, and our PCO2 also wouldn't be normal? It doesn't make sense just from an intuitive point of view. You would think the PCO2 would also be 40. Why would you have, you know, the bicarbonate not signaling anything to the respiratory center, and yet the PCO2 would be anything other than normal? So from an intuitive point of view, you'd expect it to be 40, but from a logical point of view, mathematically employing the acid-base rules, you would think that when the bicarb came back to 25, the PCO2, if it started at 30, would only go to 37, given the metabolic alkalosis rule. So I don't know if that long-winded answer answers your question, but it is sort of interesting and surprising that you could end up with completely normal numbers, but you do. So on an
Yeah,
exam,
interesting.
this is what they would give you. They would give you normal numbers. And if you're in a rush, you'd write no acid-base disorder until your mind looks at the anion gap here, sees that it's elevated, and then you have to then start thinking logically. The anion gap's elevated. I must have an anion gap metabolic acidosis, which means protons came into the blood. I have protons coming into the blood. How for the life of me could I have a normal bicarbonate? Well, I must have another process that has an opposite effect on the bicarbonate. And then you try to find out, are there any clues? You look at the clinical scenario, you see the patient was vomiting, and you go, uh-huh, I know vomiting causes a metabolic alkalosis. And that gives me the clue that there's two things going on here that must be opposite in direction, but they lead to normal blood gases and acid-base values. So that's sort of the thinking.
Gotcha. Thanks so much.
Okay, everyone. See you next week.